My name is Cormac Russell. I'm the Director of ABCD in Europe and the Director of an organisation called Nurture Development. So I'm here to speak with you about this idea that firstly the doctor cannot do everything when it comes to our health and well-being, and that secondly there is an untapped potential in communities, and largely the idea of tapping into that potential is the idea of community building. So in essence what I want to speak about is this idea of community building and how a doctor can support communities in that regard. So I think one of the challenges is that 90% of how people in the UK engage with the biomedical world is through their GP, and 40% of those who are engaging are lonely. So another way of saying that is that they're not biomedically ill. Having that number of people in a GP surgery or any kind of a primary care outlet is a real challenge. I think the challenge can only be met not by making the GP surgery or indeed the waiting room better, but by making our communities stronger. So the question is, how do we do that? We know that what determines our health and well-being are 5 key drivers. The first is our own personal agency. In other words, if I walk, if I exercise, I become a primary architect of my own well-being. The second is my associational life. There's actual evidence, epidemiological evidence, that shows that I can add 4 to 5 years onto my life by the number of clubs and groups and associations that I'm a member of. Now I know of no doctor in the world who, if I went and said to him or her, I want you using only biomedical or pharmacological interventions to guarantee that you can do something that will add 4 to 5 years onto my life. They simply cannot do it. And yet by building relationships we can, and the evidence is clear on this. The other determinants are around our environmental conditions and our economic status. The fifth and final is access to medical care. It's a strange malaise that in Europe the vast amount of money, the vast amount of energy and most policy focus is on one of those 5 drivers: access to medical care and quality of medical intervention. It's made more profoundly ironic given that 40%, as I'd mentioned, of patients who attend GP surgeries are not in need of medical intervention, but are in need of some kind of community connection. So I think it's a real big challenge, and I think the best way to face this challenge is to begin to realize that we have to stop medicalizing social and political issues, and instead support doctors to build alliances with third sector organizations and with community groups who can do what they can't. I think a doctor primarily is good around biomedical issues. What we need to figure out is a way of addressing the social issues with people who are good at addressing social issues. So I think the challenge, regardless of where you're at in your cluster, whether you're at a very early stage or you're further down, is to begin to actually look at those alliances and figure out what it is that a doctor can do best, what it is that third sector organizations do best, and what is it that only a community can do. And if we could get those relationships right, I think we could make massive, massive change. Some of the practical ways of doing that, I think, include beginning to not just see individual patients as the primary unit of change, but to also begin to think about the neighborhood as the place where change can happen. The power of reform, I think, in the health world is we're beginning to see health beyond healthcare and not just think about health in biomedical terms, but also see the social determinants of health. And I think 3 to 4 to 5 years on from where we are today in Wales, those that will be at the forefront will be people who will have figured out how to actually build community at that local neighbourhood level. So the challenge, I think, is that as the doctor and indeed as the overall medical world begins to recognise the limits of its own capacity, can it actually build alliances with other agencies that are able to do what they can't? And I think that challenge is being faced up to very well in Wales. One of the entry points that GPs have been using to address this issue of not medicalising social issues has been social prescribing. I think it's really a very laudable attempt. Recently I was asked by a doctor why it was that when he prescribes a patient time in a gym or some other practical thing which will get them more connected and healthier, they're not really likely to go and do that to the same extent that they would if the doctor prescribes them some medication. And my answer was simply to say that I think that the power of the doctor, aside from the fact that they are among the most trusted professionals in a citizen's life, I think the power is that they hold the keys to the medicine cabinet. What they don't hold the keys to is the community. Many of our GP surgeries are not necessarily as tuned into or as connected to the opportunities, the social opportunities in community, as maybe others would be, like a community development practitioner or a third sector organisation. So I think somehow we need to support our GPs to figure out how they can refer people who need to build relationships in the community, how they can support them to do that. I have become increasingly concerned that this referral mechanism, where I see GPs actually referring, for example, lonely, isolated people onto basket weaving groups, is not actually hitting the mark at all. The idea that a GP would not medicalise somebody is a good next step. I think it's progress. The idea that we'd be able to, as GPs, hand on our patients who are lonely to third sector organisations is probably another good next step. But the new frontier and the big challenge is, how do we make sure that lonely, isolated people can actually identify themselves what they care about enough to get engaged in? So instead of prescribing them basket weaving groups or 2 hours at the gym or whatever we think is best for them, that we actually figure out a way of deeply listening to what those people care about enough to act upon, and then supporting them to build the relationships that are reciprocal, not relationships where they sit passively in basket weaving groups that some third sector organisation has brokered them into, but actually in relationships where their gifts are as important to the people that are, in the community as indeed those people are to the lonely people being referred. We need to create some scenario whereby we can almost go on the journey with lonely people who, for very good reasons, have made, I think, quite a healthy and logical choice. They've made the decision to not sit in their own home, to not be prisoners in their own home, but to instead go and spend hours of their week in a waiting room, and then to go and to draw on the only, I suppose, modicum of solace and consolation they can find in their community. And that's the consolation they get from their doctors. And every so often, if you'll forgive the pun, this is slightly tongue-in-cheek, they score some antidepressants. I get that. But if we're going to create an alternative, then the alternative has to be authentic and it has to be real. And that means we've got to build relationships, not referrals. It means that third sector organisations need to figure out how, instead of just putting people in projects, they can actually broker people into genuine reciprocal relationships. I think it's possible, but I think it's going to take an awful lot of hard work. It's going to demand that we move beyond our silos and that we get serious about this idea of health beyond healthcare. My final thought. Most people who are involved in health-producing activity do not think about themselves as being engaged in producing health. They're walking, they're running, they're talking, they're connecting. They're doing things that make their lives better. And essentially, that's what we want to get more of. And I think that happens when you build powerful, connected communities. That's about interdependence in community life and not just building dependencies on services and interventions.